Okay, so we have talked about what a science-based approach to medical care for IBD means to us. Now I want to finish out this module by talking about care and self-care in IBD. And so I always start out talking to people about what I think of as the 5 steps of IBD care. And I'm going to start out with a rapid review of certain red flags. So you'll see that. Then I'm going to talk about navigating the world with IBD, navigating conventional care and alternative care and insurance companies and social situations. And then I'm going to talk a little bit at the end about mitigating certain sequelae. And that just means reducing the potential harm for some things that come along with IBD, some medical issues that come along with IBD. So the 5 steps of IBD care. So number 1 is always make sure that you are safe. Number 2 is get you into clinical remission. 3 is get you into serological remission. 4 is histological remission. And 5 is maintenance. And I'm going to talk about what each of those mean. So to make sure you're safe means to make sure you are safe enough to be getting outpatient care. I have had many patients who come to me and they're severely active enough that I think they really need to be getting inpatient care. They need to have their vital signs monitored 24 hours a day. They need to have access to urgent surgery or IV steroids, that type of thing. So once we've made sure you're safe enough for outpatient care, then our goal is to get you into clinical remission, and that means symptom-free. And that is awesome. Unfortunately, that is where a lot of doctors, and that could be gastroenterologists, primary care doctors, naturopathic doctors, acupuncturists, etc., stop. If their patient says, I don't have any symptoms anymore, they're like, great, cha-ching, I have succeeded. But I really want to stress that at Foundational Medicine, we think it is important to go further than that to the next step, which is serologic remission. Because you can have no symptoms, but your biomarkers, like C-reactive protein and fecal calprotectin, that Dr. Sheeler is going to talk about at length, that those biomarkers can be elevated, and that means you're at risk of flaring. That means you're at elevated risk of colon cancer, and you're at elevated risk of other extraintestinal manifestations. So we think it's important to not just be symptom-free, but to have your inflammatory biomarkers normalize. The next stage is histological remission, and histology is the study of tissues. So that means having your doctor do colonoscopy or at least sigmoidoscopy, depending on where your inflammation is, and take some biopsies of the tissue and send them to the pathologist to look at and examine microscopically. And if you're in histologic remission, that means your tissues do not show any signs of active inflammation. It's also known as endoscopic remission because you have to do endoscopy to take a look, or deep remission, or mucosal healing. So once you are there, you have a very good prognosis if you continue with the current care plan you're on while you're in histologic remission of staying in remission. But even so, once you're there, we like to involve people in a maintenance plan, which is basically surveillance. So if you have colonic IBD, not just Crohn's ileitis, but IBD in your colon, that means ordering a fecal calprotectin every 3 to 6 months, depending on what your history is and how recently you've been inflamed. And that can mean other things for ileal disease too. So we like these 5 steps, and I want to go through step number 1, make sure you're safe in some detail. So what I mean by making sure you're safe is making sure your body isn't flying any of these red flags for danger. These are dehydration, obstruction, perforation, fistulization, anemia, and cancer. And we do have this IBD flare guide. So if you go to our website, foundational-medicine.com, you can download the flare guide, and it's printed out in a lot more detail than I'm presenting today. And we love our patients to read through this. Sometimes people even print it and put it on their fridge or on their desk or somewhere so they can access it if they're feeling bad, to ask themselves the question, am I seeing any red flags? So dehydration, that can mean dark urine or scanty or no urine, dizziness, headaches, or fatigue, dry mouth, tachycardia is high, heart rate, tachypnea is breathing too fast, hypotension is low blood pressure. Skin tenting, this is something where your doctor will do And that's where you pinch the skin, and instead of coming down flat right away, it stays in a tent-like form. That can mean you are dehydrated or having dry mucous membranes anywhere. That could be your eyes or your gums or anywhere else if they just look dry. Also, running the most common blood test in medicine, a complete blood count, can show signs of dehydration as well. So you can be dangerously dehydrated, and if you're experiencing these symptoms, A, hydrate yourself with some electrolytes, and B, talk to your doctor and find out if you're safe to be outpatient. Obstruction. So this is often preceded by a stricture, and this is on the vocabulary section, but a stricture is an inflammatory or scar-based narrowing of the intestinal canal. And that can make stool thinner, it can make you feel nauseated, it can make stool hard to pass. But if that tightens enough and food or chyme or stool can't get through, that is an obstruction, and that is a surgical emergency. So obstruction is often preceded by stricture. You could have constipation or barely any stool. You can get bloating, nausea, or vomiting. Anorexia just meaning lack of appetite. You're not hungry for anything. And if you're having these symptoms, sometimes we will order, or whoever's on your medical team will want to order an X-ray or an ultrasound or a CT, CAT scan, or MRI, magnetic resonance. Perforation. This is when, like in that diagram of Crohn's where the ulcer went really deep, sometimes it goes all the way through the tissue. You can get an abscess. Sometimes you can get a fistula, which is the next item. Or sometimes that can just be a hole into the abdominal cavity, and that is a perforation. Usually that comes with acute new abdominal pain. You might be able to feel that abscess if the body has walled off that inflammation, and you can get septic. That means body-wide inflammatory reaction, sometimes with bacteria in the bloodstream. And if you're that kind of patient, you are bad sick. Someone's going to look at you and say, you don't look okay. This also is detectable with abdominal imaging. And fistula, same thing. This could be part of the abscess or perforation process. Some signs could be like if you have an inflammatory tunnel or fistula from your intestines into your bladder, well, you could have bubbles in your urine, or you could be getting urinary tract infections. I've seen this in my patients. If you have a fistula from your intestines to the vagina, I've only had this happen with one patient who's had stool excreted vaginally, unfortunately. And this also is detectable with imaging. Many patients with IBD can have anemia, but anemia can get significant and get so dangerous that you need iron infusions or even blood transfusions. Of course, I've had patients have all of those. So these are the red or pinkish spot when you pull down your eye. That's your conjunctiva. So conjunctival pallor is a sign of anemia, and pallor in the crease of your palms is called palmar pallor. Neither of these is a completely reliable test for anemia, but they can be signs. Being fatigued or having shortness of breath are other signs of anemia. And I had to mention cancer because it's one of the most dangerous and scary outcomes of especially colonic IBD. With anemia, if you see a rapid drop in your hemoglobin to especially below 7 grams per deciliter, then you might need a blood transfusion. And so cancer is very scary. Unfortunately, the signs and symptoms are not much help. Like, yes, there can be constipation or weight loss or blood in stool, but all of these come late or have low positive predictive value. So really the thing to do to prevent cancer is to get regular screening colonoscopy. And the current conventional recommendations are the first time should be 8 years after you were diagnosed, and then depending on how severe your inflammation is, every 1 to 5 years after that initial 8-year period. So those are the red flags we wanted to look at. And please, if you're interested in this, review the flare guide in more detail. So you ask yourself, do I have any red flags? And if so, yes, this is where conventional medicine is the best. Hospitals, IVs, 24-hour monitoring, and maybe surgeons could be your best allies here. If there are no red flags, this is where integrative care does its best work, with our goal of hitting clinical remission, histologic remission, serologic remission, all of the levels of remission. That's my goal with every patient. So once we've made sure you're safe enough for outpatient care, that is where we get into the work of hitting clinical remission, getting our patients symptom-free, making sure their biomarkers are normal, getting them so their tissues are completely normal, and then doing maintenance work. And that, how to do that, is really the story of this entire 9-module course that we hope you join us on. That's the work that we're doing with diet, with drug therapies, with supplements, with herbs, with microbial medicines like probiotics and fecal transplant, with helminthic therapy, and with lifestyle. So that's the rest of the course, and I want to leave you with a couple more things. And one is some thoughts about navigating the world when you have IBD, and the last is just mitigating some sequelae. So I want to talk about regular doctors, alternative doctors, insurance companies, and social situations. Starting with regular doctors in hospitals. This can mean primary care, like your primary care medical doctor, osteopathic doctor, or a physician's assistant or nurse practitioner. These are the general types of providers you'll see in conventional primary care, and it can mean specialist care, which could be a board-certified gastroenterologist, or the physician's assistants and nurse practitioners who work in gastro practices, and it can mean colorectal surgeons. So these are an important part of the landscape of care for IBD, and generally, these folks are really, you can expect what they'll do because it's very predictable when you're all following the same clinical practice guidelines. That is one of the blessings and amazing things about conventional medicine. When I send my patients and my friends and family to a conventional gastroenterologist, I can almost predict what they're going to say because it's really algorithmic and it's a really cohesive profession, which is awesome. It has its strengths there. And in terms of the therapeutic order, they're really using drugs and surgery are generally the only tools, which we call high-force interventions, to try to deal with urgency or palliate symptoms or relieve symptoms, relieve inflammation using synthetic tools. All of these things have their place. When you're thinking about alternative providers, this could be naturopathic doctors like me, or a lot of other types of providers, and even some medical doctors or osteopathic doctors, or PAs or NPs if they've done integrative or functional training. And so for alternative providers, we're not just going to be using practice guidelines. We're going to be using information from all levels of evidence, which makes it hard to predict. When I send my patients or friends or families to see alternative providers, I can't always predict what they're going to say because there's a lot of different schools of thought and different studies that different people pay attention to. So that's awesome that there's a broad toolkit. And also it's tricky because you're not sure what people are going to do. And then you also have people using interventions that work on all levels of the therapeutic order. And so I want to talk about a couple of important differences between conventional care and alternative care. And so if you find yourself on the spectrum where you prefer more natural care, well, this is the world where you probably want to spend more of your time. Versus if you're more interested in technological care, this is the area where you want to spend more of your time. If your symptoms are more mild, you're in peacetime medicine and you are more likely to work with practitioners like this. If your symptoms are more severe, you're much more likely to need those high-force interventions of surgery or corticosteroids, that type of thing, that these are the specialists in that type of medicine. If you're bold in seeking benefits, you're more likely to want people who use all sorts of evidence, whereas if you're more cautious and you want only the highest levels of evidence to be used, well, this is probably the type of care that's best for you. And I want to talk about this bold versus cautious spectrum a little bit here. So people who are more cautious are the type of people who follow what's classically known as the precautionary principle. Better safe than sorry. I don't want to risk something in the unknown. I want to stick with what is really well known. And if this is you, then generally conventional care is where you're going to be most comfortable and where your values will align you. And I think I made this term up. It's the proactive, I call it the proactiveness principle, better well than worried. So these are people who say, look, I don't want to be worried that I didn't try something that could have really helped me. I'd rather, think I might get well, even if I might expect some possible risks from unknown by using more experimental or therapies that haven't been studied as much. So these are the two axes to think about where you fall on them. And you might fall one place at one point in time and another place another point in time, and that is fine. So the downsides of this side is sometimes can be too closed off to approaches outside of conventional medicine. And the approach here is sometimes it's too open to therapies that might not be helping or might have risks, or too closed off to conventional medicine. And we really are always trying to find the best of both worlds. I want to talk about hospitals. So one of our big goals is to keep our patients out of the hospital. Of course, because if you need to go to the hospital, your disease severity has gotten out of control, or you've developed a stricture or a fistula or an obstruction or a perforation or something where you need the highest levels of care. And we're trying to prevent that for you. Also because sometimes people experience overtreatment at hospitals. I've had patients who have had colectomies where their whole colon is removed that they later regret. Sometimes colectomy is the right answer, but sometimes people choose it or they get convinced to do it and they regret it later. That would be an example of overtreatment from that individual. And there is risk of hospital-acquired multi-drug resistant organism infection. So that's, everybody knows, a risk of going into hospitals. So we try to keep people out of hospitals, but thank goodness they exist. Hospital care can be so valuable and life-saving, and I can't count the number of times that I've had a patient go to the emergency room and be checked into inpatient care, and I'm so thankful because it's probably saved their lives. Insurance companies. I just want to throw out a list of things to consider as you're considering different insurance plans. And for people who are looking at this in Canada or the UK or other parts of the world where everybody has insurance, great for you. I wish every American had insurance. But in the United States, we have to pick different insurance plans and pick the benefits and risks of different plans. So some things to consider are, does the plan I'm considering cover my current or preferred primary care doctor or gastroenterologist or hospital? Does it cover the biologic that works for me or the infusion center I go to? Does it cover naturopathic medicine or acupuncture or other things that I use now or want to use? Does the plan require pre-authorization or referral for specialists or surgery or diagnostic imaging? Pre-authorizations for biologics, those are usually managed by a gastroenterology practice, so the patient doesn't need to worry about those so much. Think about the math. Would a lower deductible justify higher monthly payments for the amount that you typically spend on drugs, labs, and imaging specialists, etc.? And certain meds, for example, biologics, have astoundingly high sticker prices. But patients who are underinsured or uninsured can often get low or even no cost biologics directly through programs through the pharmaceutical companies. And I've had many patients take advantage of those, and they're very important and a great gift by these drug companies. Crohn's and Colitis Foundation has a great insurance checklist here. It has a lot of, some questions I think are unnecessary, but other great questions beyond these if you want to go really in depth. We're not affiliated with them at all. I just think their checklist is great. I want to talk about managing social situations. So I don't have IBD, so I haven't had to manage these myself, but I've had many, many patients tell me about managing social situations and how to do that. So talking to friends and family about the difference between remission versus relapse. So remission is when you're in a period of no symptoms for the indefinite future, and relapse is when you've relapsed and you are in a symptomatic period, versus just having a flare. So you can, people can be confused when you're well and later you're sick again. So communicating to your loved ones that you can be well for a while and you can eat a diverse diet and you don't need to run to the bathroom and stuff, but that you might be at risk of having symptoms again later, that's a worthwhile thing to communicate to people around you. Some families have worked out code words to communicate to loved ones around them if they urgently need a bathroom or some private space or something like that to deal with urgent digestive complaints. So that can be helpful in certain social situations. Eating out. If you're going to someone else's house or going to a restaurant, it can be worth your time to talk to them in advance about dietary needs, or let them know that maybe you actually need to bring your own food if you're on a very restrictive diet. And at restaurants, check menus and bathroom availability in advance. There are a couple apps that I've had patients use. The Flush Toilet Finder and Map has 4.7 stars with over 7,000 reviews. But just so you know, the whole thing is kind of automated. So it's just a spot to find bathrooms near you. But my patients say that, maybe the bathrooms aren't open or you don't have info about them all the time. But it's useful. Crohn's and Colitis Foundation of America has this app called the We Can't Wait app. And it's more like the Yelp of bathrooms, where people are writing their own reviews. Oh, this is your bathroom is supposed to be only employee access, but they'll let you use it. And they actually have a digital We Can't Wait card to show to people to say, please let me use your employee bathroom because this is an urgent situation. I have a medical condition. Employment. I've written letters to patients, employers, letting them know that they may need more frequent bathroom breaks than other people, or may need to have a cubicle or something else positioned close to the bathroom, or they may need to take time off work at certain times. So people with IBD want to work, but may have to have their work situations limited at sometimes for medical reasons, and your doctors can write letters to your employers explaining why that is. Parking, I have helped people to get handicap placards so they can have special parking, so they can be really close to a bathroom when they park. That can be really critical as well. And then palliative treatments for special occasions. So in the drug module, Dr. Sheeler will talk about loperamide and other drugs that are not necessarily a good idea to use long-term for a variety of reasons, but you can use short-term to slow down your bowel frequency so you can attend a special event or something like that. So that can help you navigate a social situation at some times. The last thing I want to talk to you about is mitigating certain sequelae. We had a whole list of extraintestinal complications and sequelae, other things outside the intestines that can happen to people with IBD. And I just picked out a few that are really common, and there are things to think about that are important that I want to mention at the end of this module. So the first one is C. diff. C. diff used to stand for Clostridium difficile. Now it stands for Clostridioides difficile. Everyone just calls it C. diff. This is a bacterium that produces a toxin, and people with IBD have a 10% lifetime risk of getting it. Sequela number 2 is venous thromboembolism, or VTE. People with IBD have a 3 times higher risk than non-IBD people at getting a VTE. And the last one is osteopenia or osteoporosis, thin bones that can be so thin you're at elevated risk of fracture. So let me talk about each of these. The crazy thing about C. diff is the main risk is that you'll get diarrhea. And people with IBD are often having diarrhea anyway. So it can be really hard to tell if you have C. diff sometimes, because you're just like, oh, my diarrhea got worse. Sure, my diarrhea gets worse all the time. So when you're in a new flare, it can be to your advantage to ask your doctor, hey, is this a good idea to get tested for C. diff? And sometimes we are surprised when we find C. diff and we treat for it and the patient gets better. We thought it was a flare, turned out to just be an episode of C. diff. And that's treated in basically 3 ways. Vancomycin is the antibiotic that's been used for the longest, that's still used for it. It's also called, was just called vancomycin. Fidaxomicin is also called Difficid, and that's a newer one that works even better, but it's very expensive. And then FMT, or fecal microbiota transplantation, works just as well as antibiotics, and actually I think sets you up for less C. diff in the future and for less IBD in the future in a better way. And there's a whole module on microbial therapies where Dr. Sheeler will talk about FMT. Venous thromboembolism. The symptoms of this are calf pain or swelling or redness, or sometimes you can even feel what feels like a hard band because this is really a thrombus or clotting inside the deep veins of the calf. It's detectable through a blood test called D-dimer or through an ultrasound of the calf. I've had patients who have these, and these are treated at anticoagulation clinics. You really want to identify them when they happen and treat them appropriately, because if that thrombus becomes an embolism, it can end up in your lungs and you can get what's called a pulmonary embolism, and that can be fatal. So you really want to know about these. People with IBD are at higher risk. And when you travel on long airplane rides, especially if it's for like 4 or 5 or 6 hours or more, because you're not moving on the airplane and because there's decreased air pressure in the cabin, you are at even more risk. So I have some things to recommend for my IBD patients going on long air flights. Stay hydrated, get up every hour or two and move around and stretch your calves, stretch your feet, and wear compression stockings. All of these things are going to reduce your risk of getting VTE on a long plane ride. And then osteopenia or osteoporosis. So even without prednisone or other glucocorticoid or corticosteroids, even without those, people with IBD have a 50% higher risk of getting bone thinning. But if you've had many courses of glucocorticoids, you definitely need to get a DEXA. And then there are things we can do to talk about: drug therapies, yoga therapies, nutritional therapies, vitamin therapies, and supplements and other things to increase bone density. So there's a whole course of things to understand how to potentially mitigate harm with IBD. You can go to our website, foundational-medicine.com, and you can see our IBD flare guide and other things. Check out our YouTube at Foundational Medicine or Instagram at foundational_medicine, and hope that this has been helpful for you. Oh, and also here is the references for this talk.